Okay, good afternoon, everyone. Samantha Gamble-Spar here. Today is Tuesday, September 12th. The time is now 1:09, and I'd like to call the Impact Committee meeting to order. Thank you guys so much for being patient with us as we dealt with our audio and technical difficulties here in San Diego. At this time, I'd like to establish a quorum for our committee meeting, and I will take roll at this time. Samantha Gamble-Spar, present. Dr. Edward Ray, Vice Chair.
Present.
Dr. Andrea Espinoza. Okay, Dr. Espinoza is not here. Jan Johnson Griffin, nurse practitioner.
She's not here as well.
Okay, thank you. Dr. Kevin Maxwell, present, nurse practitioner. Thank you. Sally Pham, nurse practitioner.
Present.
Thank you.
Thank you. We can hear you.
Betha Schnell, public member.
Not present.
Okay, so currently we have 3 members absent, and we have 4 present, so we have met our quorum at this time. I would like to turn it over to the moderator.
Good afternoon. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. We will also query the site locations, San Diego, Los Angeles, and Sacramento, if there are comments or any other communication. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. We will also, again, query the various locations. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. If you're in a location, again, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda. Items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on in the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute the microphones automatically. Thank you.
Thank you, moderator. We are now on to agenda item 3.0, public comment for items not on the agenda and items for future agendas. Here in San Diego, we do not have any public members here present at this meeting.
Oh, sorry, you're waiting for me. We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
Board moderator, while we're waiting for people to come into the WebEx to make a comment, I want to check with Dr. Ray. Do you have any public members, public participants at your location?
We do not.
You do not. And Sally, do you have any public participants at your location?
Yes, I do.
Is there anybody at your location in Sacramento that wants to make public comment?
No, not at this time.
Thank you.
Thank you. Committee Chair Gamble Spar, there are no public requests for comments on the WebEx. There are no public requests for comments in Sacramento, nor LA, nor San Diego. Would you like me to close this window?
Yes, moderator, thank you. Moving on, agenda item 4.0, review and vote on whether to approve the previous meeting's minutes from March 7th, 2023. Reaching out to my fellow committee members, are there any corrections from those minutes that we need to discuss at this time? Okay, hearing none. May I have a motion to accept the minutes from March 7th, 2023 as written?
Motion to approve.
I'll
Dr.
second.
Edward Wright? Who was the second? I'm sorry.
Sally Pham?
Thank you.
This is Reza. Just in going forwards, please state your name when you're making a motion for our note takers. Thanks all.
Thank you. Okay, let's call for a vote. Samantha Gamble Spar, yes. Dr. Edward Ray,
Yes.
Dr. Andrea Espinoza, Dr. Jan Griffin, I'm sorry, Jan Johnson Griffin, nurse practitioner. My apologies.
Dan,
Dr.
you would only
Evan.
need to call for the vote on from the people that are attending. So you do not.
Okay,
need to
thank you.
call.
I do, just for clarification, are the members that are not here, are we expecting them to be absent the entire meeting?
Yes, we are.
Okay, thank you. All right, Dr. Edward Ray was a affirmative. Dr. Kevin Maxwell, nurse practitioner.
Yes.
Sally Pham, nurse practitioner.
Yes.
Okay, Samantha Gamble Spar, yes. We have voted to accept the minutes for March 7th, 2023 as written.
This is Reza. I apologize to interrupt. I may have missed it. Did we go to public comment on that one?
Oh, no, we have not. Thank you, Reza.
Okay, I know we went from the motion to the vote and I wasn't sure. Having done the vote, maybe open it up to public comment.
Yes, we will at
Any
this time.
comments
Thank you,
and that changes
Reza.
anything? Okay, thanks.
Thank you. Moderator, would you like to open up for public comment, please, at this time?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
Sacramento, have anybody that wants to make a public comment at their location for this agenda
No.
item? Thank you.
No.
There are no public members here in San Diego.
Committee Chair Gamble Spar, there are no public requests for comments on the WebEx. There are no public requests for comments in Sacramento. There are no public requests for comments in LA, Dr. Ray?
That is correct. There is no one here. Yes.
Thank you. Would you like me to close this window?
Yes, thank you, moderator. As we've already voted, the motion will carry. Now we're ready to move on to agenda item 5.0. Discussion and possible action regarding our meeting dates for 2024, which was sent out in the supplemental materials. currently looking at the supplemental materials, the dates that have been booked were March 2024 and let me just make sure I get there. March and September, keeping on cue with what we've done this year. March 26, 2024 and September 24th, 2024. I believe those are still on Tuesdays. And any discussion from the committee at this time regarding those days?
One update for you guys. I know that previously we had gone towards the beginning of the month. We did move it towards the end of the month in order to accommodate the potential legislative calendar. That way, if there is a bill that is introduced that is specific to nurse practitioners, we can bring it to the committee for input.
Thank you for that clarification, E.O. Melby. Okay, hearing nothing from the committee. Moderator, can you please open WebEx up for public comment, please?
Would you like to make a motion first, please?
Oh, yes. A little rusty today.
That's okay.
May I have a motion to accept the meeting dates of March 26, 2024 and September 24th, 2024.
Second.
Second, Ed Ray.
Thank you, Dr. Ray. Now you can open up to public comments now.
Thank you. All right, moderator, we are ready for public comment at this time.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment.
So we're putting Samantha down for the having made the motion, is that correct?
For the first, yes.
Yes.
And while we're waiting for members to let us know if they want to do public comment on the WebEx, it is noted that there are no public members in attendance at the San Diego or the LA area noticed locations.
Thank you. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing in the question box. I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Gamble Spar, there are no public requests for comments on the WebEx. As noted, there are no public requests for comments in San Diego or LA. Are there any public requests for comments in Sacramento?
No.
Would you like me to close this window?
Yes, please, moderator. Thank you. We're ready to call for a vote to adopt March 26th and September 24th, 2024. Samantha Gamble Spar, Chair. Affirmative. Dr. Edward Ray, Vice Chair.
Yes.
Dr. Kevin Maxwell, Nurse Practitioner.
Yes.
Sally Pham, Nurse Practitioner.
Yes.
Okay, the motion passes. We will adopt those dates for 2024. We are now on to agenda item 6.0, where we will receive a report from our E.O. Melby regarding the implementation of AB 890 as it stands currently. E.O. Melby.
Thank you very much. So currently with the implementation of AB 890, we do have the 103 application that is out and being utilized. It is not being utilized to the extent that was predicted. I know there was a news article in January that was released that talked about a potential of 20,000 applicants wanting to apply to have the 103 application. To date, January 1/18 to 2023 till August 17th, 2023, we have only received 3,141 applications for the 103 nurse practitioner. in meetings with stakeholders, it was noted that the BRN has withdrawn 347 applications that did not qualify for the 103 application due to national certification being a legacy or retired applicant. Legacy or retired certification. On further information and pulling the record and seeing for duplicates, those were mostly duplicative applications with some applicants submitting 10 separate applications. Once we were able to look at that information, it was only 123 applicants that to date have not qualified due to a legacy or a retired national certification. For clarity, the legacy and retired national certifications, there are 4. One is geriatric, one is adult, one is adult acute, and the other one is the adult psychiatric mental health nurse practitioner. Those legacy and retired certifications were not reviewed. Their exam was not reviewed by the Office of Professional Examination Services, as they do not have a current exam and they do not have an examination that can continue to be reviewed as outlined in that subsection 105. So because of that, there are some people that have not been able to qualify for the 103. We have been in meetings with legislative staffers to discuss a path forward to see if there may be a statutory or a legislative fix that could move forward with that. However, if there is a path forward currently, and I do want to make sure that people do have the ability to understand that our nurse practitioner programs within the state of California have all agreed to do a gap analysis. And so if you were to have a previous education and previous national certification exam, and you wanted to re-attend a school to take a couple courses to be able to qualify for the current national certification exam, they are willing to work with you on an individual basis to see what you have and what you will need in order to qualify. So that can occur. And I have heard that there are several people that are pursuing it. Some of the other reasons that we're hearing that people are not applying for the 103 is that it's limited to a group setting. The 103 NP, to work without standardized procedures, must work within a group setting along with a physician and surgeon member. And that goes against some of the nursing corporations that have been set up. It specifically does not include a nursing corporation as part of those group settings. It does, however, include a medical corporation. With the nursing corporations that are currently set up, those nurse practitioners work under the supervision of a physician with standardized procedures. And that allows them to continue to work in that manner. And that is not something that is allowable per the current statutory guidelines for the 103 NP. Additionally, we are moving forward with preparing to get ready for the 104 nurse practitioner application, looking at late 2025, early 2026, as it does make ensure that there's a 103 NP must work in that location, as a 103 NP for 3 years before they can qualify for the 104, with the caveat that a DNP prepared NP may get time credited toward them for their clinicals that are done in the specialty area that are post-master's preparation. And so I just wanted to give you guys an update on that. Do you guys have any questions or anything that you would like to ask or get further information on that I haven't covered in this update?
EO Melby, I did have one question. This is Samantha. Can you hear me?
Yes, I can.
Okay, sorry, just making sure. As part of that gap analysis that's being offered here within the state, I'm guessing that as individuals are working with these nursing programs, that they are ending with a postmaster's certificate in order to qualify to take the examination again?
Yes, correct.
Okay.
That is my understanding.
So programs that originally had not been offering postmaster's certificate for transition into a new specialty are now going to be offering more of those programs in the state of California.
That is what we're hearing, yes.
Great, good to hear that. Thank you.
And just for further clarification, there is no negative effect on current employment for anybody that does not pursue a 103 NP. They can continue to work under the traditional model of the NP underneath standardized procedures within their current positions. And so if they do not pursue the 103 to move to the 104 pathway, the employers that we have met with have ensured that there would be no ill effect to those nurse practitioners. Additionally, if you do get a 103 NP, you can continue to work under standardized procedures within your employment setting, and you are not required to work as a 103 in all of your employment locations. If you do not work as a 103, however, for those 3 years, you would not be able to qualify for the 104.
It's Kevin Maxwell. Do you know of any other legislative fixes or anything on the horizon regarding 890?
The California Association of Nurse Practitioners has been working closely with legislative staffers, and we've had some questions. We've had specific questions on what exactly in language from AB 890 prohibited the board from moving forward with the legacy and retired certifications. We did report that out at the prior NPAC meeting to let you guys know what section that was. And to be additionally more clear on that, it doesn't necessarily prohibit the BRN from pursuing to license the retired and legacy national certifications. What would have to be done is we would have to create a separate exam, and that separate exam would have to be given to those applicants to verify that the competence for the 103 independent and the 104 independent practices can be done in a safe manner. It has to be comparative to the current national certifications. If you were to look at that section in the statutory language that asks for OPES to review that, I'm quickly pulling it up myself here real quick so I can reference that. The OPS was charged with doing that review to ensure that that minimum competence was met for independent practice. And when OPS reported back on it, they let your committee as well as the board know that the current, which are 8 national certification exams, population focus exams, are able to show that that competence has been met. And so with this, there did say in 2837.105 4, it says, if the assessment performed according to paragraph 2 identifies additional competencies necessary to perform functions specified in subdivision C of section 2837.103, pursuant to that subdivision that are not sufficiently validated by the National Nurse Practitioner Board Certification Examination required by subparagraph A of paragraph 1 of subdivision A, the board shall identify and develop a supplemental exam that properly validates the identified competencies. So that would be the path forward. We would then recontract with OPES to look at those remaining retired and legacy certifications. And then we would essentially use the identified sections that were used for the review of the current national certifications and then make a exam that the nurse practitioner that has a legacy or retired certification would need to then take and pass to qualify. There are pros and cons to that, right? There are pros where that would allow for potential movement to a 103 NP or a 104 NP down the line in California. The con is that's not a national certification, correct? And therefore, that doesn't necessarily ensure that the license would be transferable outside of California. So with California and Kentucky, I believe, being the two states that do not require national certification for licensure, that may not be the correct path forward. Additionally, in 2008, when the statutory language was updated around nurse practitioners, that is when it was required for an advanced degree to be obtained. And prior to 2008, when these national, these retired and legacy certifications were in place, there was no standard education requirement for a master's degree or higher. So there are a lot of different areas that need to be explored and looked at in order to move forward if that's something that the either the legislator decides to address in this year or next year. It is a 2-year legislative cycle, so it could be addressed at any point. Just with a quick update, though, I believe that the session closes on Thursday. So something would have to be introduced this year very quick in order for the session to move out of Thursday. If not, it could potentially be introduced next year for the second year of this legislative session.
Thank you.
Thank you.
E.O. Melby, I guess kind of piggybacking on Dr. Maxwell's question in talking about legislation and moving forward, has there been any discussion from any of our stakeholders regarding a full practice authority bill?
I'm not sure what you're referring to as a full practice authority bill. I would
I
need
guess-
a little more.
I guess in not having a transition to practice bill.
I have not been involved in any discussions around not having a transition of practice. The discussions that I have been in is to allow for the retired or legacy national certification to move to the 103 and the 104. Those are the only discussions that I've been involved in regarding regarding statutory updates through the bill process at this point.
Okay. Thank you. And since we're discussing and you're giving a full report and we've been kind of involved, I guess one of the things I'm hearing from public members is continued hesitancy as it relates to 103, and that many employers are not, what's the word I'm looking for, encouraging nurse practitioners and are not supporting 103 NPs in those specific areas, in the group setting areas that they are allowed to practice in. And we discussed with our public members, I wonder if you can kind of just reiterate that as well, because that continues to be an issue and question that I receive often.
Absolutely. The unfortunate outcome of that is the Board of Registered Nursing has no jurisdiction over any of the healthcare employers. And therefore, we cannot force anybody to employ the 103 NP. Just like we can't force them to employ the traditional NP. It is a employer's choice on whether or not they choose to employ an NP at all. And if they do choose to employ an NP, on how they would make their job description, duty statement, abilities, any of that whether they would keep it to working under standardized procedures or they would support them in moving to the 103. That, along with us not having the ability to force a provider that is assisted the nurse practitioner through the mentorship and additional clinical experiences as part of the transition to practice, we cannot force them to sign or attest either. So we are limited in our jurisdiction on creating the pathway to licensing and establishing scope of practice, etc. But we cannot force employment or other providers to attest. So it does limit what the board can do, but we are hearing that as well, that some of the current NP employers are choosing to continue to have them employed under standardized procedures in the traditional NP role. That is something that would need to be addressed through various organizations and not part of the Board of Registered Nursing, which is only mission is to protect the public.
Thank you, Melody. Thank you. Any other committee members have any questions before I ask for public comment? Okay, hearing none, moderator, will you please open the forum?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate if they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I would like a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Michelle would like to make a comment. 1 second, please.
What the heck? Hello?
Go ahead.
Sorry.
Go ahead.
It
Nope,
said I
you're
was
fine.
disconnected and I was like, what happened? I had a question regarding the 103 application because I actually just received a notification of my application being withdrawn, and part of it said that I did not hold a national certification in the area needed, even though I have the ANCC Family Nurse Practitioner certification. And then the second part, I'm thinking that my provider has not yet signed. And so I can take care of that, but it's asked me to resubmit. And so I'm wondering how we can fix those things, or whom we can reach out to if we receive this and need some clarification, because as I said, my certification is up to date. And so I'm not certain why that part was included in that. Thank you.
Thank you. It seems to be potential that we're kind of fine tuning that process as well as we hear. So feedback is imperative for us to do this process better. You can go onto our website. Under the section, there's a section that says Contact Us. And in the drop down there, there's licensing questions that you can reach out via email. Additionally, if you were to go into the executive section for contact, Macaulay Fusarins, the chief of licensing, her email is on there and you can email her as well. And so we can address that. I will definitely recommend email as the preferred method of contact because we are aware that our phone systems fill up very quickly. And it is very difficult to get through. But if you do send an email, we are able to assist you in that manner.
Thank you.
Thank you for your comment. Rebecca would like to make a comment. 1 second, please.
My name is Rebecca Goldfader. I am one of 6 nurse practitioner quality liaisons in the Golden Gate service area personally, but in Northern California for Kaiser Permanente. We represent over 500 nurse practitioners who are currently in active practice, seeing patients across the Northern California region. And my comment has to do with the number of applications that have been received at the BRN. It's not surprising to me that the number of applications that were received did not meet the expectation of what you thought would be coming, because the ability of this bill to expand our practice is inhibited by the way in which employers are responding to the law. And this is an extremely frustrating process, not only because of the legacy or retired certifications for some of our NPs who have been in practice for over 30 years, but also because the nurse practitioners who are interested, who are meeting the eligibility requirements, don't see how this could benefit them if they're choosing to stay with the current employer. Now, Kaiser's a huge employer in California and looking to be a huger employer across the country. And I'm very, very concerned. I realize the goal of the BRN is to protect the public, but you're knocking this bill off at the knees when large employee groups, medical groups, are not able to, or choose not to take the benefits of what this bill has and recognize them for their employed nurse practitioners. And I want you to know the level of frustration. I, for one, am a nurse practitioner of 31 years. And I know that while I was able to obtain my 103 nurse practitioner certification, I'm doing a presentation tomorrow to nurse practitioners in San Francisco who continue to ask me, why would I go through this? What benefit is it to me when Kaiser's not going to change? And let me tell you, my group of 6 nurse practitioner quality liaisons, we are mightily involved in attempting to get our employer group to change. Mightily involved. However, it is like pushing a boulder uphill. And I do want you to hear those sentiments and know where we're coming from, and realize that for those of us who follow scope of practice bills for years, we recognize that this is a huge step forward. However, we have been knocked off at the knees. Thank you.
Thank you. So I'll take a second to address that and to provide some additional clarification. The board is only able to carry out what statutory authority has been given to them. We have no statutory authority to force employers to employ the 103 NP at all. We also do not have any statutory authority to expand the group settings that were set forth in the statute, specifically delineating which group settings can support the NP to work in the 103 setting. So to make a statement that says the BRN has cut them off at the knees, that is not something that the BRN did. We can only do what is allowed for us to do within statute. When given the statutory language, it was provided to this committee, the Nurse Practitioner Advisory Committee. The committee was separated into 3 subcommittees who took the section 101, 103, and 104 and reviewed those, did extensive research, met with stakeholders, and provided recommendations to this committee, which then the committee voted as a whole to provide those recommendations to the board, and the board accepted those. So if there is to be change that would support the nurse practitioner to push that boulder up the hill, it would have to effectively be made through the bill introduction process. You would have to have a bill writer, somebody that would put a bill through. It would have to be voted on by legislators, and it would have to pass and then be put into law. Once it would be put into law, the BRN would be able to make movement on that. And so that's something I wanted to make sure that we truly clarified, that it is not the BRN that is hindering the progress of the nurse practitioner. in the 103 role. An additional clarification that I truly think needs to be shared at this point as well is what was put out there during the bill process. There was a lot of conversation around what this bill was going to do, what this bill promised to do, and what several organizations thought that the bill did. Unfortunately, that was a lot of miscommunication and misinterpretation. And a lot of those statements were released prior to the final language that was signed and put into place by the governor. And so the language that was turned over to the BRN, that is in our statutory language as part of the Nurse Practice Act, may be very different than what a lot of people were led to believe that was going to be there. And so with the assistance of this committee, as well as legal counsel, whose job is to specifically go through the statute, see what the board has authority over, and then write regulations that could only be given based on the statutory authority. We worked through that as a whole to have it the most expedited manner as possible. And specifically, there was statements within the bill that became law that made it very clear that the legislators' intent was not to create any undue or unnecessary burden to the licensure or practice. And we took that to heart, and we moved forward as quickly as possible with that. The transition to practice stayed almost true to form as it was in the statutory language. And we moved through that. OPS decided that after they completed their research and looking at that, there was no additional exam that needed to be done. All additional kind of hurdles that a nurse practitioner would have had to complete had those outcomes been different. The other thing that is really clear when you're talking about scope of practice is this bill did not change necessarily scope of practice. What this bill did, in the language that was brought forth after it passed and became statute, was address the supervision. And so the nurse practitioner is able to continue to have the same scope of practice that they've always had. What this bill did is that when you qualify for the 103, you are able to work under that scope of practice without standardized procedures. And without standardized procedures, that practice must be done in a group setting for 3 years with no negative dings or whatever you want to call it on your license. And then you can move to a 104. Once you move to a 104, you can work in any setting that you choose to, and you would not need to have standardized procedures as well. So what this bill essentially removed was standardized procedures. It didn't necessarily alter the scope of practice. And so hopefully that is clear too. And if you have continued public comment, I'd be happy to hear from you after I gave you that additional information.
Sure. I mean, my additional public comment is simply this. When we have a law that enables nurse practitioners to finally, in California, be in a place without the requirements that we've had in the past, yet our largest employers are not creating a pathway, recognizing this, despite internal advocacy on the part of the employed nurse practitioners, we're at an impasse. I realize that the BRN does not have any jurisdiction over large employer groups within the state. That's something that's very clear. And yet, I think it's an important point to be brought up in a meeting like this when most nurse practitioners are employed by large employer groups such as Sutter, TPMG, UCSF, etc., that we are at a place with this law where we're needing to create some alternative pathways forward based on the response to the law by employer groups. And I realize that the BRN has no jurisdiction over that, but it's a point that I want to be heard in this meeting. And I do appreciate everything that you said, Loretta. Thank you.
Thank you. And I appreciate you bringing it forward. That is a discussion that we hear all the time. And to be able to put out there that this is not something that the board can address actually gives us the opportunity to kind of give you guys a path forward as well. And that is to contact your organizations, have your organizations work together to meet with the employers and move that forward. But that is not something that the BRN can do. If there's something that comes forward in our Nurse Practice Act that is something that would give us any kind of statutory authority, we would then uphold it at that point.
Thank you for your comment. And Nancy Trego would like to make a comment. 1 second, please.
This is Nancy Trigo. I'm a geriatric nurse practitioner. Can you hear me?
Yes, go ahead, ma'am.
Yes, we can.
Great. So I'm a legacy NP that is denied 103 status on my application, which was a huge disappointment after I've advocated for this kind of a bill in California for over 15 years. So I wanted to point out a couple barriers to achieving 103 for the legacy NPs. We did take the national certification so that we have achieved that requirement. But in order to sit for another exam that might be crafted in California, that wouldn't be a national certification exam, number one. And number two, we would have to sit in a program, an NP program for our population foci in order to have the transcripts to retake the exam. And after all that, then we would have to achieve the transition to practice hours after we've taken another exam. So do you see what I'm saying? It's an arduous process that would take maybe 5 years after you go to school, sit for the exam, and then restart your 3 years of transition to practice. Am I correct?
I'll give one area of clarification, and that is that you only have to have the national certification in the population focus that is, one of the 8 that is accepted prior to application. But your transition to practice, those hours can be completed ahead of the national certification. The national certification is needed for licensure as a 103. It is not needed for completion of the 103 transition to practice hours. Now, to provide just a caveat onto that, those practice hours do have to be in the same population focus of your national certification. So if you were an adult GERI national certification holder, which is one that is qualified, if your work as a geriatric nurse practitioner, it is similar focus, and those hours may, and I can't state that they will, but those may qualify you for getting that transition to practice. That would come through your review of the requirements that are set forth in regulation and statute when you attest to completing those on your application. And then the provider that has mentored you through the transition to practice hours, that had that additional clinical experience, if that provider said that you met those requirements, then that would be done. That is not something that is done or validated through the BRN. That is validated through your attestation, as well as the provider who mentors you through the transition to practice, that attestation. And if they believe that you have met all the qualifications or the requirements, for the transition to practice, then you would be able to move forward. So it would be done on that gap analysis. As long as you have a master's degree. I do have to put that out there. There are some nurse practitioners that have been licensed in California prior to 2008 that hold a legacy or retired national certification that do not have a master's degree in nursing. And so it is a requirement for completion of the transition to practice and moving into the 103 that you do have to have a master's degree as a nurse practitioner as well. So I wanted to make sure I put that out there, because if somebody had a certificate for an NP that wasn't master's prepared because they were licensed prior to 2008, and that they were licensed under what California refers to as Method 1, which does not require a national certification at all, that nurse practitioner may not qualify, whether or not the legacy or retired certification is addressed in legislation.
I understand. I do want to point out that I sat through the OPS workshops. There were several of us who are geriatric nurse practitioner experts that volunteered our time for the OPS process. It was a 2-day workshop, and we tediously went through the current national exam and linked questions with clinical acumen. Well, if we were considered experts to achieve that process with OPS, and then OPS turns around and tells us that we can't have, or we're not able to be a 103, I just think that's very short-sighted. And I think that the OPS absolutely should be recommissioned to look at those legacy certifications, exams. I think that was very short-sighted and narrow-focused.
So to provide some clarification on that as well, is OPS did not state that you guys would not qualify. They did not look at the retired and legacy national certifications. They were not reviewed, they were not looked at, and so they did not opine on whether or not those legacy or retired national certifications met the standards for independent practice. Specifically because the language said that it had to have a current exam. And the APRN consensus model that was put forth by NCSBN was adopted in 2008. And that consensus model has pre-alignment national certifications and post-alignment national certifications. Those pre-alignment national certifications are those legacy certifications that ultimately were retired. The post-alignment are all of the certifications that OPES looked at, and the certifications that OPES did make the statement that they believe that the independent practice was validated by those exams. So hopefully, again, that provides some additional information for you. And if the Nurse Practitioner Advisory Committee wants to agendaize and make a motion on a future meeting of setting OPS up to look at the legacy certifications, that could be a possibility. but I do want to make sure that I believe legislation would have to come forth in that as well, because of the statement on 2837.105B that says the examination process shall be regularly reviewed pursuant to section 139. There is no examination process for any of the legacy or retired certifications. That does not exist. So therefore, the way that the law was implemented that the BRN has to follow, there is no current process that we can do to facilitate retired and legacy certifications through this process. Again, that does not say that the BRN cannot develop a supplemental exam, require the legacy and national certification holders to take that exam prior to being able to move forward as a 103. So that could be a possibility, but writing and implementing the exam does take time. That is time that we could go ahead and move forward with, but that doesn't guarantee that the NP that holds a national or legacy certification would be able to pass that exam. I know as a RN that if I had to go back and take the NCLEX, I probably would not pass. It's been years since I took that exam. And it has nothing to discount my expertise or my ability to be a nurse. It just means that I'm not educated to the current standards that the NCLEX now test. And that's exactly what happens with these legacy and retired certifications, is the people that hold them are not educated to the standards that the new test. And that's why the schools are doing the gap analysis to give you that education, to prepare you to sit for those exams so that you can pass successfully and then be licensed.
Thank you for your comment. Mary McHugh would like to make a comment. 1 second, please. Mary, are you able to unmute?
In the chat, she's put on that she is muted.
Yeah, I'm sending the request to unmute.
I know there's a delay sometimes.
There she goes. There it goes.
Okay.
Go ahead, Mary. Mary, are you there? Okay, I'll come back to Mary. Laura Starr would like to make a comment. 1 second, please.
My name's Laura. I'm a adult gerontology acute care nurse practitioner. I've been working in California for almost 6 years. And I just want to first, I'll try to keep this brief because I want to echo a lot of the statements that have been made. I'm working as a nurse practitioner. I have experience in my specialty and I have 103 status, but my current employer does not recognize that. And the answer that they give to me when I ask why not is because they say they're confused by the regulations and they're not quite sure how to implement them at an institutional level. These regulations make sense at an institutional level. My current service line employs so many advanced practice providers that we're actually out of surgeons to sign up to be their supervising physician. So we're kind of capped. And so I realize that the Board of Nursing does not have power over the legislation, but they do have power over the regulations and the communication around those regulations. So, and the second point that I want to make is I know that the Board of Nursing's mandate is to protect consumers. However, when consumers can't access healthcare, they are at risk. And so I just encourage you guys to maybe be as aggressive as possible about making these regulations that you do have power over as open and liberal as possible, because my practice is being muted by the current regulations. There are things that I am trained and educated to do that I cannot do because of paperwork, and it's extremely frustrating. And so I just want to echo all of these sentiments that other people have made and just add my own. Thank you.
If you could send me an email that lists the regulations that are hindering you, I would love to be able to look at that further. I'm not aware of regulations that would hinder your practice. And so I would love to be able to look at that. And if it is confirmed, bring it forward to this committee for them to take a look at as well.
Thank you for your comment. We'll go back to Mary. 1 second, please. Mary, go ahead.
Board moderator, she has been able to make some comments in by typing. If she is not able to unmute, we can take her comment in type form and then close public comment.
Okay, she's unmuted. She's green, but we just don't hear her.
You might not have a microphone or a headset in the equipment that she's utilizing.
Do you want me to read her comment or do you want to read it?
I believe there was a comment. It did say she suddenly got muted while I was trying to make my comment. So I don't know if that is still an issue. And further back, she did make a comment and said, is it possible for the BRN to keep track of the number of NPs who complain that they are unable to find a 103 placement? And no, there is not a way that we would be able to do that. That involves us in personnel issues, and that is not something that the BRN can be involved in. And so that again would have to be directed to your organizations that would assist you and help you with that. And that's the only comment that I do see from her in the comment section, board moderator.
Yes, I see that too. Okay. All right. Yeah, she's still green and we're not hearing her, so she possibly could have a microphone issue.
Okay. We can close out public comment at this point.
Perfect. There are no other public requests for comments in the WebEx. There's no public representation in Los Angeles or San Diego. Are there any public requests for comments in Sacramento?
No.
Thank you, Sally.
Thank you. Committee Chair Gamble-Spar, there are no public requests for comments. Would you like me to close this window?
Yes, please close it, moderator. And thank you for all of the public comments. We hear you loud and clear, and know that even members on this impact committee are suffering and dealing with the same issues that our fellow MP colleagues are dealing with as well. Okay. Thank you, E.O. Melby, for your feedback and all of the great information that you shared with us. We are now ready to move on to agenda item 7.0, discussion and possible action regarding input from the Impact Committee on possible changes to the BRN disciplinary guidelines and to provide recommendations or guidance when the board is considering disciplinary action against a nurse practitioner. We had discussed this at the last meeting. We had quite a brisk and robust discussion and feedback from not only E.O. Melby, but Reza, our legal counsel, as to what specifically the guidelines and the processes as a nurse practitioner who is receiving discipline from the BRN looks like. I am going to turn it over to my fellow committee members who have any input or feedback or additional discussion as it relates to this matter.
Sally Pham, I have a question. Are we talking about in terms of discipline just a 103? Or are we talking about all NPs, current licensed NPs?
This is Reza. Laura, you're on mute, but you have all NPs under your this committee's scope and under the process that we're dealing with now with the disciplinary guidelines. So you're not limited necessarily to just 103s, 104s. That said, if there are specific reasons why something should only pertain to a 103 or a 104 that's in a even more kind of unique practice setting. Of course, we don't have 104s practicing right now, but you can carve out 103s or 104s if there's some reason to do so for in terms of the disciplinary guidelines or the recommended terms and all that. Does that help?
Yes.
Now that I am off mute, I'll add just real quick. The current disciplinary guidelines have been effective in providing guidance to several legal experts, as well as our board members and board staff, for all RNs, all nurse practitioners, nurse anesthetist, clinical nurse specialist, and nurse midwives. We continue on a daily basis to utilize them for any complaint that is received at the BRN. The one thing that stood out when looking at the current disciplinary guidelines is if somebody is in the process that are on probation or in the intervention program that has to go to work, that needs to have supervision at work. What is currently required is equal to or higher than for a worksite monitor. So if you are an RN, you can have a worksite monitor that is a nurse practitioner or an RN. If you're a nurse practitioner, you are required to have a nurse practitioner be a worksite monitor for you. You cannot have an RN be the worksite monitor for you if you are performing the duties of a nurse practitioner. With the caveat that if you're a nurse practitioner, you can absolutely still work as an RN. So if you were employed as an RN and not as an NP, then an RN could be a worksite monitor. So we've been able to work well within the disciplinary guidelines up until this point. With the new independent practice, as we move into the section, the 104, it does allow you to have an independence that has not been something that the board has had to work within the probation or intervention units. And so with that, it was pointed out by Dr. Ray and shared at a prior meeting that the med board has an ability that those independent practitioners could potentially utilize as part of this update to the disciplinary guidelines. And I can let Dr. Ray kind of speak more on that because that's not my area of expertise.
No, thanks to you, Melby. I mean, yeah, I don't have them right in front of me, but I know when we last met, we talked a little bit about this, and it can be just an idea for a framework to model off of. Obviously, the BRN is not going to make itself a carbon copy of the medical board, but just the idea that they address some of the concerns about professionalism that are unique to independent practitioners that the BRN should probably take into consideration as they're sort of developing and evolving how they approach discipline issues specific to those practices. And the comment that I was going to make actually, just real quick, was that at least what I envisioned our role as a committee to be in addressing disciplinary issues is perhaps focusing on the areas specific to independent practice, the things that make 103s and 104s unique. I mean, the day-to-day, licensing issues or practicing without a license or whatever, that kind of bread and butter that the BRN constantly has to slog through is probably not something you need to drag in front of the committee. But and without necessarily creating any more work for anybody, it would be nice maybe if during our quarterly meetings, we just have a very, very brief overview of like, what are the types of problems that are coming up more and more frequently? Like, what are the issues that are most commonly specific to these 103s and eventually 104s, since obviously we don't have 104s in process yet. So anyway, that's my comment. I just think that this is something that we're probably going to be, it's going to be a work in progress as we try to figure out what our role is in helping the BRN address some of these things. Because the regulatory language, you know, is almost certainly going to change over time, right? To address some of these things as they come up, stuff that we never thought about.
Yeah. EO Melby and Dr. Ray, I agree. One of the things we discussed last time, and Reza, our legal counsel, did a great job of breaking down that process of how you know, you can go through the administrative discipline and have the due rights and the process of actually moving through discipline with the BRN, and that it's already pretty well ironed out as far as, like Dr. Ray said, the day-to-day practice issues that people may have right now, whether they have standardized procedures or not. I think, like Dr. Ray was saying and EO Melby was saying, as we move more into independent practice, that is an area that we will have to focus a little bit on. And we had discussed, or I was thinking of, and I had kind of thrown this idea around, and I don't know if this is the right area to have this, but to have after, just to kind of monitor and see what happens as 103 MPs are now starting to practice, and then reevaluate what has happened in March and get feedback, like Dr. Ray said, to kind of see those areas of where we might be useful in giving recommendations, or even based upon the seriousness of the cases that we're seeing. So, and then also even having a stakeholders meeting perhaps to discuss any additional things that people may be concerned with or things that we're seeing in the community as well. So, and I think we had kind of discussed all those things before. Did everybody hear me?
I did.
Yes.
Yeah.
Okay. It was quiet. Does anybody else have anything else from the committee? Anybody else have?
I thought I heard somebody say they had a question. Was that you, Sally?
No, I was questioning like whether our discipline was, you know, are we focusing on everyone, all the MPs categories, or just the 103 and 104? But I think Dr. Ray, you know, from my understanding is that we're focusing more on the 103 and 104 because a lot of the current discipline process is already in place for our current nurse practitioners that are not 103.
Yeah.
Yeah, and I think it's in place and effective with the 103 as well. The 103, because they're limited to a group setting, we are able to carry out the probation or intervention work placements as needed. I don't think that there's going to be any kind of negative effect with our current disciplinary guidelines. I think more so where we do have to have some kind of regulatory update will be as we move to the 104.
EO Melby, will we start having some discussions about any regulatory language next year, anticipating in March regulatory language as it relates to possible discipline issues or anything, any regulatory language as it relates to the MP, the 104 MPs? Will there be a need for that in March, or do you anticipate anything like that?
There will be a need, yes. And actually, we started January of this last year where we had the nurse midwife and the nurse practitioner advisory committees jointly noticed, so that Shannon Johnson, the chief of enforcement, was able to go through the disciplinary guidelines for both of the committees to be able to see what's currently out there and to start kind of looking at this process as a whole. Currently, the disciplinary guidelines do not have specific call outs for each of the four independent, each of the four advanced practice RN roles. knowing that the nurse anesthetist has been functioning independently for years. They do so, however, within group settings and healthcare organizations. And so we're able to have those monitoring type situations so that the probation and intervention processes can be completed. The nurse midwife and the nurse practitioner, as your roles grow into more independent manners, that is where the focus needs to kind of be narrowed to, so that we can start looking at, okay, what happens if a midwife or a nurse practitioner own their own nursing corporation and they're not working with the physician under standardized procedures, and they do end up having something occur, and the board would like them to continue to practice, but do so in a manner that protects the public. And that is typically done when they're on probation or intervention with a worksite monitor and some limits to their practice based on whatever the issue is that brought about the disciplinary or intervention outcomes. So with that, that is where we cannot complete that process the way that it currently is. We would have to have a person that is licensed similarly to the probationer or probationer or intervention advanced practice RN with that scope of practice, monitor that person while they're at work. There's three different levels of monitoring, and one is maximum, where that person is with you the entire time that you're working. The step down from that is moderate, which you are there 50% of the shift. So if it's an 8-hour shift, it's 4 hours that worksite monitor has contact, and there's 4 hours that you can practice more in an independent manner where the worksite monitor doesn't need to be there. Minimal is 2 contacts per day, or 2 contacts per shift. Sorry, I'll be more clear with that. And with that, that is the piece that when you are practicing in your own practice, you might not be practicing with another provider that's equal to you. And that's the part that is difficult to carry out in our current disciplinary guidelines. Additionally, within those confinements of the workplace, we may limit access to narcotics. Well, if you've got a business that requires you to access and utilize narcotics, then you would need somebody that could do that, so that the patients can continue to get the care that would be needed. So there are various things that come into play that need to be evaluated as we look at the independent practitioner with the midwife and the 104 NP.
One more question, EO Melby. The 2 contacts per shift, just for clarification, is that expected to be done in person? Because contacts can be via phone or.
So currently, it's in our disciplinary guidelines, and then the decision and order comes out that provides the ability for the nursing education consultant that's within our enforcement unit to take everything into consideration and look at what needs to happen there. Sometimes a judge will dictate what level of supervision that is. Not always. There is a process that it has to go through. And again, the minimum supervision states 2 times a shift. And that is for a person that has shown that they can perform on minimal supervision without causing any patient harm. Somebody that this is entering the probation or entering intervention would not be put on minimal supervision. There's a reason that their license was disciplined, is because they are a safety risk. And so to have somebody just check in twice a shift, that's really, the BRN's not doing any good by putting somebody onto minimal supervision in that kind of a setting. There are other guidelines around if someone were to be home health, et cetera, that talks about visits to the worksite locations, et cetera. And it does go through that as well. So it really just depends, again, Samantha, on what occurred, what the accusations were, what they were disciplined for, what kind of work setting it is, and moving forward. There's also, as part of that disciplinary process, and I think I failed to mention this before, was the expert consultant that is called in that gives advice on the case, and that is a person that is equal to the nurse or advanced practice RN that is going through that process. It is not just board staff that may not have any idea. It is a nurse practitioner that would be looking at the nurse practitioner practice. It is a nurse midwife that would be looking at the nurse midwife practice, nurse anesthetist that would be looking at the nurse anesthetist practice, and so on. And that person has to be current in practice as well. And so there are specific guidelines that they have to have 10 or more years of experience, minimum of 5 years in the clinical practice setting, and they cannot have any prior or current disciplinary as well.
Thank you, Yolnelby. Any other committee members have any questions or comments at this time?
I would like to make a comment. It's Kevin Maxwell. I think it will be telling to see what sorts of actual discipline problems arise to help guide us as far as, where we need to focus, as opposed to us sitting around and trying to come up with things that we think people are going to get into, and just actually, sit back and I guess wait until we see what the trends are, and then we can focus our efforts that way.
I think one of the things for clarification on that is we're not trying to get in the weeds where it is looking at the things that people are actually doing that bring discipline. It's either negligence, it's either incompetence or gross incompetence. It's either, working outside your scope of practice, unprofessional conduct. The law does not get into the specifics of what it is. It qualifies them into those subsections. So there might be many things that a nurse can do that would justify unprofessional conduct. There might be many things that a nurse could do that would be gross negligence or incompetence. But that is what is brought up and disciplined, not the individual error, if that makes sense. I covered this position the last 8 months as we were looking for an NEC to fill in. And I had to do worksite placements for many, many different RNs and APRNs and such as they went through the process. And it's vast. You get some that it's a documentation error. You get some that it's a diversion issue. You get some that it's a knowledge deficit. It's a complete practice miss that shouldn't have happened. And you get some that are emotional, behavioral, mental health kind of issues. It's not a one size fits all, but those come under gross negligence, incompetence, unprofessional conduct, etc. And so that is how that is determined at a more of a legal stance. And Reza might be able to kind of opine more specifically on that. We're not looking in the minutia that says a nurse practitioner missed this on assessment, or a nurse practitioner did not notify the physician in a timely manner, or the nurse practitioner did not document the Schedule 2 meds appropriately and utilize Cures data bank. That's not the type of kind of review that is being done. It is, you take all of those and then they get discipline brought against them that says one account of gross negligence, a second account of unprofessional conduct, a third account of incompetence, if that kind of clears it up for you.
This is Reza. Also, I'm not sure if it's helpful, but for what it's worth, just a reminder that during the formal discipline process, there's expert witnesses who are involved, usually on both sides, who are kind of opposing and presenting information on the standard of care and the specific facts of the case and all that. And in cases that involve a nurse practitioner, where it has anything to do with their nurse practitioner practice, there would be an expert definitely involved on the complainant's side to even advise the board's complainant about whether there was a violation. So and then the respondent, the person who is the licensee under consideration, has an opportunity to present, provide their own witness and rebut the opinion of the board's expert and all that. So that's just to say that there are, in terms of dealing with these real individualized situations of, if an NP didn't report this or that, like Lori was saying, those types of things are, I think, largely captured and addressed by that involvement of the expert witnesses who are, in these cases, NPs. But the broader things that either we anticipate being a problem, or where we need to provide some guidance, or as we go along, the things that seem to be recurring again and again, those are areas that can be addressed in the disciplinary guidelines. So, Lori was talking earlier, I think Dr. Ray, who originated the concept, we've anticipated a potential issue with 104 NPs who will be on probation because of the kind of unique nature of that. So that's something that could be addressed in the disciplinary guidelines, that we say, okay, in these situations where you've put 104 on probation, their supervision requirements are going to differ in these prescribed ways. Other things, you don't necessarily need to differentiate how a 103 or a 104 will be treated under the disciplinary guidelines, because there's nothing unique to it's not necessarily something unique to their 103 or 104 practice. And also in the next agenda item, I know we're going to be discussing a subcommittee to look at enforcement cases for trends and things like that. So that could be useful in, as a couple of committee members have said, as we go forwards, identifying those areas and those issues that may need to be addressed. So, I mean, for the time being, it's, we're open to other specific issues, but the one that's been brought up relating to 104s, I think we have the opportunity now to, if there are any concrete ideas, get those out. Otherwise, I think that's something that board staff can work on offline, as far as coming up with solutions and language, and using, looking at other boards as current models and things like that. So
And when any regulatory language is done through board staff, it would come to the NPAC to get input as well. So very similar to what you guys did for the 103 and 104s is regulatory language was drafted. It was provided to you guys. You guys provided input. You made a motion on whether you accepted it or you amended it and then accepted it. And then that recommendation went forward to the board. And then the board would have to take a look at it, amend it, accept it, whatever, and then move that forward for us to move forward with the process. And it starts a very long process. It's usually a couple-year process, which is why our board staff is currently working on some language around the supervision for the 104 NP or the more independent nurse midwife as well, and nurse anesthetists, et cetera, as we move forward.
Any other discussion from committee members before I open it up to the public? Okay, hearing none. Moderator, will you please open the forum for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box. Sorry. I would like to make a comment. Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and will move on to the next member of the public. I'll pause for a moment for members of the public to type in I would like to make a comment. Laura Starr would like to make a comment. 1 second, please.
I just sort of quick question. I don't currently see an advanced practice nurse sitting on the board. And I was in light of all of these regulatory changes. Is that something that's in the works of being changed? Did the board makeup get changed? I'm just curious if there's going to be an advanced practice nurse on the board in the near future.
There is a vacant advanced practice position on our board. Our board does not appoint to our board. That position is filled through the governor's office, and we are not involved in that process at all. We are noticed once they appoint somebody, and at that point only do we get involved and we onboard them. But we are not part of that appointing process. We have received a couple public member appointees this year. And so there has been some attention given to our board, but we have had a vacant RN position for many years that has not been filled through the governor's office. And so there's no way for us to tell.
Gotcha. Thank you.
E.O. Melby. There was for the APRN, she's talking about the BRN position, correct?
That is
there was a call for
position.
applications.
So some more clarification on that. Elizabeth Woods was the APRN member of our board. She served her 2 4-year terms and her 1-year grace period, and she is no longer a board member as of June 1st. And so for 3 months, we have had an APRN vacancy on our full board, one of the 9 members.
I just wanted to address the issue that I know that there was a call for people who were interested in that role that went out through the governor's office, I believe, because I saw it posted myself.
Good to know. I did not see it posted, so that's fantastic news.
Thank you for your comment. Committee Chair Gamble Spar, there are no public requests for comments in the WebEx. There are no public members in Los Angeles nor San Diego. Are there any public requests for any in Sacramento? I'm sorry.
Go ahead.
Hi, this is Catherine Hughes. I'm a registered nurse and the executive director of the Nurse Alliance of SEIU California. Just a quick question regarding EO Melby's last statement. Is the board staff working on proposed language to address discipline for independent practice, or could they be? Because it sounds like we're kind of in a time crunch, and so we should be, I didn't hear if you said they are doing it or they could do it.
Are doing it. Yes, we are in a time crunch. We are doing it as soon as language is drafted. We will put it to the Nurse Practitioner Advisory Committee.
Thank you for your comment. Are there any other comments in Sacramento?
No, thank you.
Thank you. Committee Chair Gamble-Spar, there are no other requests for public comments. Would you like me to close this window?
Yes, thank you, moderator. We are now at agenda item 8.0, in which we're going to discuss the establishment of a subcommittee to review final dispositions of disciplinary cases against MPs on a quarterly basis to identify the trends and enforcement issues that we've been talking about in the previous agenda item and as part of the regulatory language possibilities. I will open up the floor for any committee members who have any input as it relates to this issue.
Is it correct that subcommittees are made up of 2 members? And if that's true, I think it would, I think for the benefit of the public, that always having at least one NP on that would be important, whether it's just something that we rotate through so that everybody's not doing this, that just 2 members aren't doing it all. And it might make sense just to have a rotating schedule. But I would recommend that it always be at least one NP.
And that is correct. There are 2 members that would make up a subcommittee. We cannot have more than that.
EO Melby and committee members, I have yet to serve on a subcommittee during this impact committee process, and I would like to have the honor of serving on this subcommittee, possibly if chosen.
We have 1 person volunteering. Is there a second person that would want to volunteer to establish a subcommittee for the disciplinary?
I wanted to second Kevin's idea. I think that's great, having a rotating schedule so that everybody can participate at some point, or at least anyone who's interested. Just putting that out there.
I was wondering if we review the final dispositions and of the disciplinary cases, how about if we disagree with the discipline?
So I can jump in on that. This is Reza. This subcommittee's task would be to identify trends, issues, things like that. So if you disagree with, say, the outcome of the case or the level of discipline that was imposed, this is not to go back and correct that or to relook at it for the purpose of reopening any of that. At that point, it is a final disposition and it's done. But if you notice that there appears to be a trend and or even a single issue that stands out significantly enough to you that maybe is a problem that needs to be addressed, it's something that you would raise and identify for the committee to discuss further and look into solutions, perhaps in the form of something, editing the disciplinary guidelines or, something else, whether it's regulation or whatever. But it's to identify problem areas that we might seek to address in the future, not to reopen individual cases, or there'd be no authority legally to go back and, you know, I assume that's what you're
Yes.
asking
Yeah.
about.
No.
Okay.
So EO Melby, the other question I have is that the staff now is working on disciplinary language, but we don't have trends yet. So what are they working, like how do they go about that?
So again, the disciplinary language that is currently in place, without any edits, has served the nurse practitioner, nurse midwife, the nurse anesthetist, the clinical nurse specialist in their advanced roles, and the nurse anesthetist in independent practice for many, many years. That language is not what's being looked at and addressed. What is being looked at and addressed right now is the practice monitor. That is the issue. We do not have a practice monitor as part of our disciplinary guidelines. When you have a nurse practitioner or anybody that is disciplined, part of that discipline when they reinstate the license and they put them on probation is to get them back to work. Getting them back to work requires them to sometimes do a refresher course or sometimes do some continuing education or some anger management, depending on what it is that they are being disciplined for. And then when they work, they are given a work site monitor. The issue with an independent practitioner, any of the advanced practice RNs that have an independence practice, is the worksite monitor that is currently used is a coworker. So to say, as an RN, I'm disciplined. I have other RNs that work with me at the Board of Registered Nursing. I couldn't supervise, so I couldn't do this role. But say that I was a nursing education consultant. Say I was a nursing education consultant and I worked at this as the team of NECs at the BRN and I was disciplined. I would have a fellow NEC that is licensed as an RN that would watch me as I worked to ensure that I would not bring harm to the public while doing my job. And that would allow me to go through, typically it's a 3-year probation period, work and show that I can do this without harming the public. And that supervision is typically gradually decreased. Now, that worksite monitor, because as an independent practitioner, I don't have a coworker that is a nurse practitioner that I'm in business with. I may not have that. I might have be a nurse midwife that I don't have a second nurse midwife that's working with me. So the part of the disciplinary guidelines that need to be addressed is that practice monitor. That's the part that needs to be addressed. It's, again, not talking about the individual issues that a person might be disciplined on. It's once they are disciplined, how do they complete the process to get back into full practice in the way that serves, right? So that's the issue that's being addressed. Again, when we were kind of talking about the disciplinary process, I was trying to explain, and it looks like I did not do it that well. But when a person is brought up in discipline, we have an expert practice person that opines on every single case. That person must be licensed for a minimum 10 years. They must be current in that practice, in that specific area of practice for 5 years. They're probably going to be more qualified than myself or any of the members on these committees. Honestly, they are in direct practice doing this every single day. And in addition to that practice, they serve as an expert witness with this. As when they are brought up on probation, they have what's called cause for discipline. They might be disciplined due to a criminal conviction. They might be disciplined by another board. You might have the dental board that did an investigation that found that there was some kind of an issue. One of the things that we do see sometimes are discipline that's brought on by the Commission on Teaching Credentialing, because they work with our RNs that are school nurses. So we'll see discipline come that way. But we might, other than the criminal conviction or maybe another board like through the Commission on Teaching Credentialing, we might see something that is gross negligence, that is incompetence, unprofessional conduct, something to that, or a general violation of the Nurse Practice Act. That is able to be managed through our current disciplinary guidelines. There's nothing that needs to be addressed with that, because it's done throughout the legal process using experts, and the whole thing is done outside. And Reza, you might have a better language for this, but it's utilizing the legal system that's already established outside of our board. It goes in front of a judge that makes the recommendations for the discipline. The part is, once they have the discipline, that's why you guys would be looking at it after the fact, right? See if there are any trends, see if there's anything that's done. If they have the discipline, how do we get them back to work? That's where the board really comes in to say, how can we support you? And we support them through a worksite monitor. But independent practitioners do not have a worksite monitor. They would need to have a practice monitor. They would have to have somebody that they would hire that would come in and work with them at their business and watch them either through the minimum, moderate, or maximum supervision that is ordered. And again, that changes as they progress through the probationary process. And so that's the part that needs to be addressed right now in the disciplinary guidelines, because we don't have this ability. So currently, if an independent practitioner, say a 104, has something that's brought against them and they go through the disciplinary process and they have their license disciplined, they would not be able to work in a setting where they are the only nurse practitioner, because they have no ability to have a worksite monitor. We need to, as the board, give them that ability to continue to work as an independent practitioner, as a nurse practitioner. And that is done right now through the med board by having a practice monitor that that person hires in and utilizes to complete the probationary period. We do not have that. So hopefully that provided additional clarification.
Thank you.
And can I just add, this is Reza. So the question was whether, how, if we haven't looked at what issues are coming up, how is board staff, working on something to address this? We haven't really looked at the trends and things that's correct, but this was an issue that was a specific issue that was brought up in anticipation. We can expect that this is going to be a problem and a deficiency with our current disciplinary guidelines. So it's just one issue that has been brought up and that staff are working on, and will bring forward any possible solutions based on, other models or whatever ideas that are brought forth. But again, that's only one issue. So this committee can identify other issues if any come to committee members' minds. You can also take the one that's been brought up about supervision or practice monitoring for 104s and give some direction or some recommendation for staff as they are going down the path of trying to solve that, or not. And staff will bring back what's the best product that they can, and you can then look at it and give some direction at that point. So just hope you're clear on kind of what's going on with the this committee's input on the disciplinary guidelines.
With all that discussion that we just had, is there any other person who would like to serve on this subcommittee?
I would like to, but like I said, I don't want to monopolize it, and I wouldn't mind having a rotating, subcommittee where different people can have a chance to serve and, chime in. But I think it's going to be interesting to see the trends. I think really along the lines of what EOMLB and Reza said about looking at what the issues are that come up as the regulations go into effect.
This is Reza. If you're looking to have a rotating, membership of this subcommittee, I suppose you could either establish that now in advance or simply establish the membership, the makeup of the subcommittee for now, and maybe with the expectation that at the next NPAC meeting or 2 meetings from now, however long you want that term to be, that it's, they present their findings and you relook at the makeup, and if anyone else wants to participate, you can rotate it then.
There's 3 members that are not here today, so then we probably need their input too if they want to be part of it. I certainly would like to serve on this committee too.
That's a fair point, Sally. Oh, I'm sorry. I'm sorry, Sally. I meant to say that louder. That is a fair point, to see if any of our other committee members would like to serve. I think I am the only person who has not served on a subcommittee this entire time. I don't know what the best action would be, as we don't have another meeting until March in order to establish this subcommittee. So I want to be respectful, but I don't want to hold up the potential work that could be being done in the interim prior to our next meeting in March. So I don't know what the best solution to that is, EOMLB and Reza. What do you think?
There's a couple different things that we can do. So it sounds like there are 3 of our 4 members today that would like to be on this subcommittee, and there's only 2 that could be on the subcommittee. This can go to a vote. We could do a vote for Sam, do a vote for Dr. Ray, do a vote for Sally, in any sort of a makeup that we could. If somebody wanted to make a motion, that motion can be made, and a second, and a vote would go forward. So if somebody made a motion that said, I would like to establish the subcommittee consisting of Sally and Dr. Ray, or establish a subcommittee consisting of Sam and Sally, or consisting of Sam and Dr. Ray, then a second would be done, and you'd be able to do that. And those, if that vote passed after going out to public comment, that would establish a subcommittee, and you guys can work on that until it is noticed at another meeting that there may be some changes that would want to be done. It's not a permanent solution. So if the vote is put forward, if someone does a first and there is no second, then of course that motion doesn't move. If there's a first and a second and the motion doesn't carry, then a second motion can be made, and that can move forward as well. I do think, taking into consideration that there is 6 months between this meeting and the next meeting, half a year, that a lot of information can be looked at, and there can be some work done. I would recommend that establishing the subcommittee today with some membership would be the path forward that would be the most conducive to any work getting done. But knowing that if it is an agenda item in March, we could re-agendaize this, and we could open it back up for potential change. But as it's been discussed here, if there is a rotating schedule, if somebody serves a 1-year term or a 2-year term, then it looks like that could be a path forward too. And then we would just notice in the fall of every year to appoint new members to the committee. We could set that up in a charter of some sort. I would encourage a motion with a second and a vote to occur today to establish a subcommittee so that we would not lose 6 months worth of work while we wait for the next nurse practitioner advisory committee to be established.
Can I motion to have a subcommittee to review final disposition of different cases that is on a quarterly rotation base?
A quarterly?
Mhm.
So you want to make a motion to establish the subcommittee that would review the cases quarterly, or that the subcommittee membership would be reviewed quarterly?
Both, right? So can we do that?
I would really recommend not doing a quarterly membership appointment, one, because you guys don't meet quarterly. So that would not be of benefit. And since you do only meet twice a year, I would recommend doing at minimum a yearly appointment, or it doesn't give you a lot of time to actually dive into that and move kind of items forward, if that's understood.
This is Reza. So she, the agenda item uses the word quarterly. I presume that's where Sally is getting that. But I think Lori's right. What I would envision is the next meeting in March that there's an item similar to this that includes the findings of that subcommittee up until that point and looking at the makeup, and we can determine then if you want to mix it up and rotate. So for now, I'd suggest making that motion, but leaving out the quarterly piece and also addressing first the makeup of it. Lori, explain you can do it by motions and see if they fail or succeed. It might be simpler if with a little discussion ahead of time we could narrow down who wants to be on this subcommittee, and who's willing to bow out for this round.
Yeah, I mean, I don't feel strongly about it. If Sally is really interested, I'm happy with her and Samantha taking this on this round, and maybe in the future, if we do this rotating thing as often as you guys or as everyone on the committee feels is necessary, that would be fine with me.
And I think it's also important to note that the subcommittee will be reporting to the entire committee. So there will be opportunity for feedback and input, much like the subcommittees for the transition to practice. Everybody had their feedback available, and input was heard.
Thank you. So it looks like Dr. Ray bowed out gracefully. I appreciate that. So a motion would need to be made to establish the subcommittee, and it would be with Sally and Sam, and then to come back to the NPAC in the March, when at the next meeting. I don't have the date right off the top of my head. And so we would need that motion in a second. We would need to go to public comment, and then we would have to come back and do the vote.
Right. This is Samantha Gamble-Spar. I motion that Samantha Gamble-Spar and Sally Pham serve as the subcommittee to review final dispositions of disciplinary cases against MPs and present that information to the Impact Committee moving forward.
Second, Ed Ray.
And with that motion on the table, the time is 3:07, and so I'm going to ask the moderator to please open the forum for public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Cynthia Yovanov would like to make a comment. 1 second, please.
Hi, can you hear me?
Yes, ma'am, go ahead.
Perfect. Hi. I've been listening to the discussion all day on and off. I think that my only comment, even though I have a lot to say, but I will stay on just this agenda item. In regards to the subcommittee for disciplinary actions, you guys already made a motion and voted to start with just the 2. However, my recommendation is to actually have some content experts that review some of these cases, especially because of the comment surrounding 103s and future 104s. As we know, that there are nurse practitioners that will not qualify as a 103 at this time, that may not be able to speak to a nurse practitioner that is going through disciplinary actions that will be a 103 or is a 103. And partly it's because of the fact that maybe their practice prerogatives don't allow them. What my biggest concerns are the comments about monitoring. Now, as an RN under disciplinary actions, yes, there is monitoring, as Loretta Melby had mentioned on site. It is very different as a clinician in those clinical settings. What I am recommending that one is that there is consideration of content experts to be in this subcommittee so that there's no bias. Reporting back to the NPAC is fine, but it would be especially important to have content experts weigh in as well, especially those that are practicing in clinic settings that are familiar with, bylaws, billings, any kind of disciplinary actions get reported back up to the National Provider Data Bank. As we all know, the BRN is a lot more difficult in regards to disciplinary actions than the California Medical Board. That is a known fact. And of course, it's a public safety, but I would recommend that because that there are public members, content experts, especially as a 103 and moving into a 104 is part of this subcommittee. If not, obviously this round, but maybe the next round, only because it will affect people's livelihood if we do not approach this in a manner that's fair and equitable in regards to disciplinary actions. And that's just all I have to say. So thank you.
Thank you for your comment. Committee Chair Gambles-Farr, there are no other public requests for comments in the WebEx. There's no public representation in San Diego or LA. Are there any public requests for comments in Sacramento?
No.
Thank you. Committee Chair Gambles-Farr, there are no other public requests for comments. Would you like me to close this window?
Oh, yes, moderator, thank you. Sorry, I was on mute. We have a motion on the table. We will call for a vote at this time. Is there any other discussion needed at this time?
I was wondering if, this is Sally, if we could add an MP to be part of the subcommittee. The motion to include an MP at each of, when we establish a subcommittee now and the future.
The subcommittee is made up of members of this committee. It is not made up of members of outside. That's not how that is. Now, any subcommittee can meet with any experts that they choose to and talk to anybody about anything. They're not limited to that. What the subcommittee cannot do is have conversations with other members of this nurse practitioner advisory committee. That is why a subcommittee is established. But those two members of a subcommittee can talk to whoever they need to outside of this. They just can't talk to other members of this committee.
This is Reza. Can I just clarify? Sally, are you asking whether we can specify that of the two members of this committee who are on this subcommittee, that at least one should be an NP?
Yes, yes.
Okay. I think you could specify that. I think if we currently have that, then you've met that, and the next time around we could make sure that that's addressed again. I don't know that I don't see us putting, a specific charter together for this subcommittee, at least at this point. So I think we've currently met that, and going forwards, I would suggest just, keeping tabs of who we appoint to this. But also what, what Lori said was also correct, but I think that was speaking more towards the last public comment that was received, that our subcommittee, even this round is not precluded from getting information from others. And also these cases are all public documents. We're reviewing final dispositions. So these, if there are folks out there in the public who had an interest in reviewing these cases, they're public record and either can be obtained from the website for specific individuals or requested from the board as a records request. So, anyone can really look at these cases, and if they want to identify trends and issues and things like that, bring it forwards in public comment.
Thank you, Reza, and thank you, E.O. Melby, for that clarification on those 2 points. I appreciate it. Sally, I think we can definitely discuss and make sure that this is we can bring this onto our agenda as an item potentially for March of next year for any additional discussions or term limits as we've discussed. Okay, there is a motion on the table, and I'm calling for a vote. Samantha Gamble, board chair, yes. Dr. Edward Ray.
Yes.
Dr. Kevin Maxwell, nurse practitioner.
Yes.
Sally Pham, nurse practitioner.
Yes.
Okay, we have a quorum, and we will move forward with myself and Sally on the disciplinary subcommittee. Okay, and that was our last agenda item. I appreciate everybody holding on and kind of keeping up. We just went a little bit over, given we were a little late getting started due to our technical problems. I don't think that there's anything else that needs to be said. E.O. Melby, do you have anything else that you'd like to share? Okay, it's nice seeing you guys all again. Thank you guys for all tuning in. I hope you guys enjoy the rest of your years. We won't see you again until March. Happy holidays, be safe. And I call this meeting adjourned at 3:16. Appreciate your time.
Thank you, guys. Bye-bye.
Thank you. Bye.